For those of you who are online, sorry, I was just introducing our speaker, Dr. Funmi Olaoye, who's one of our current addiction medicine fellows, as well as a public health and preventative medicine resident at the University of Alberta in Edmonton. Dr. Olaoye has a keen interest in addiction medicine and public health strategies for addressing substance use. In addition to her medical career, she's an international award-winning singer and recording artist. And through her music, brings messages of hope, love, and peace to communities around the world. Very happy to be introducing her today as she's speaking to a topic that I think is very is currently very topical. It's something we're hearing often in the news, both in British Columbia as well as elsewhere. There's a lot of conversation around bed-based treatment. So she's here to demystify this subject for us a little bit today and talk to us about bed-based treatment options and therapeutic communities for substance use disorders. I will be back at the end to help field questions.
Yeah, hello everyone. I hope you can hear me. And please, if you can hear me at any point in time, please kindly signify so that I can speak louder. Okay, thank you. So today I'll be speaking about bed-based treatment and therapeutic communities for substance use disorders. I respectfully acknowledge that I am a humble guest on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I do not have any conflict of interest. And here is the outline of what we're going to be talking about today. So we're going to be talking about what bed-based treatment is, bed-based treatment considerations, the types of bed-based treatment, what do therapeutic communities mean, the therapeutic community approach, the types of services available in bed-based treatment, what residents are saying about bed-based treatment, the limitations of studies, areas of future research, and I'll be summarizing with the key points. So here are the objectives of what we're going to be talking about today. I've already mentioned them in the outline, so I won't be going over them again. So what is bed-based treatment? There's no actual standard definition or acceptable standard for bed-based treatment. However, McQuaid et al. Defined bed-based treatment as programs in which overnight accommodation is provided for the purpose of substance use or gambling addiction treatment. This excludes shelters for people experiencing homelessness, correctional facilities, mental health facilities, where the main objective of residents is public safety or mental health needs. So what are bed-based treatment considerations? Who are the people that are best suited for bed-based treatment? Ideally, you'd expect that people that have significant challenges with control of their substance use, for example, people that have multiple relapsing events despite being treated for their substance use, or people that have significant relationship issues that could impair the management of their substance use. Those that have increasing severity of substance use. I would like to also highlight that all programs do not necessarily achieve all these goals. So it varies across different residential or bed-based treatment. So what are the types of bed-based treatment? Again, for types of bed-based treatment, there's no acceptable standard. Bed-based treatment means different things to different people. But however, SAMHSA classified types of treatment as outpatient, inpatient, and residential. But for the scope of this presentation, outpatient is actually out of scope, so I'll be talking about that. So I'll be concentrating on the framework using inpatient, residential as either long-term or short-term. And before I proceed, I would like to define these terms because during the course of the presentation, I'm going to be talking about these terms. So inpatient means staying at a hospital or treatment program overnight for probably few days to few weeks. Residential treatment, of course, means staying or living in a treatment program for a longer period of time. For residential, the treatment for more serious conditions may mean staying there for, staying with the program for a year or more. And duration of stay, as for short or long term, is not consistent throughout all studies. SAMHSA, that is Substance Abuse and Mental Health Services Administration, defined short term as 30 days or less, while long term is greater than 30 days. However, some studies define short term as few days to few weeks, and long term as 6 months to 12 months or more. So this kind of varies across different studies. And examples of residential treatments, especially for special populations, include residential treatments for youth, indigenous, LGBT, which is quite rare. And I'd also like to mention that withdrawal management is usually the first component. Again, there's no acceptable standard for the types of treatment and the types of bed-based treatment. So, okay, it was getting stuck, actually. Okay, thanks. Right. So regarding inpatients, still talking about types of bed-based treatment. So inpatients is usually for those who need like 24-hour care for their substance use or mental health. A lot of these programs are connected to a hospital or specialized treatment units. And they provide various services, ranging from detox, stabilization, psychiatric evaluation, and treatment for the substance use. Short-term residential treatment, of course, from the word short-term, it's brief, maybe intensive, and usually offered in specialized treatment facilities. The types of services offered there include like psychosocial, interventions, including, may include intensive counseling, group therapy, as well as medical management, with or without. And long-term residential treatment is more of a comprehensive care, usually offered at residential facilities. Therapeutic communities is actually a type of long-term residential treatment, and I'll be still talking more about this in subsequent slides. The types of services offered there include very highly structured programs with focus on development of people's skills to prepare them for the outside world. So therapeutic communities, what does that mean? It's a type of long-term residential treatment focused on helping individuals change their lifestyle through a community-based approach. This usually would involve clients and staff as participants in management of a caring community to foster psychological, social, and behavioral change. Therapeutic community may be traditional or modified therapeutic community, and this may include, clinicians, other service professionals, including counselors, administrators. The duration of stay in a therapeutic community varies from 15 to 24 months to 9 to 12 months. Again, for this, no acceptable standard for services provided, or length of stay. So therapeutic community approach is summarized as community as method. So community as method means that the community itself provides a context for social learning. Being a member of that community establishes expectations or standards of participation in the community. So expectations are set and individuals are assessed in a non-judgmental manner to determine whether they're actually meeting these expectations. So these are program stages for a traditional therapeutic community. There are 3 major stages. You have the orientation, primary treatment and re-entry. These program stages, it's just like a model. And this is according to Assam Essentials of Addiction Medicine textbook by Iron and Brennan. So the first stage is basically orientation, kind of, acquainting people that are in these facilities, about what the program is about, the regulations, what the community expectations are, getting to provide information about the philosophy of the program, as well as, peer instructions. The next stage involves more of like group meetings, and this could be daily. It could include things like daily therapeutic meetings, counseling, and other form of psychosocial intervention. And people are assessed, of their progress by the staff and their peers. The first half of the third stage, here people are being prepared, to be separated from therapeutic community, and people are actually, their skills are enhanced to prepare them to be able to make autonomous decision when they leave the therapeutic community. And there's so much emphasis laid on life skills, educational, and their vocational goals. The latter part of the third stage, here people are actually separated successfully from the therapeutic communities with the hope that they'll be able to, get to do something when they get out of the therapeutic community. And this includes getting jobs, maintaining their families, and probably, securing a future for themselves by going to school. So what is modified therapeutic communities? So modified therapeutic communities was actually developed from traditional therapeutic community framework in the 1990s, more commonly abbreviated or short-term program, about 3 to 9 months. MTCs serve different populations, especially those with concurrent mental illness and substance use disorder, people who experience incarceration, women with children, youths as well. So the adaptations made to therapeutic communities to form modified therapeutic communities include increased flexibility. So increased flexibility may mean more flexibility in program activities, shorter duration of various activities. Decreased intensity may mean less intensity of interpersonal interaction and fewer sanctions. Greater individualization may mean greater sensitivity to individual differences and greater responsiveness to the needs of the residents. So talking about the services that are provided in in residential treatment, this could be non-medical or medical. So the non-medical activities vary, across various residential treatment, and they could include, the list that I kind of provided here. Quite a number of them are group focused. For example, you have a 12-step program, the CBT, relapse prevention, etc. And not all residential treatment actually provide all these services, but these are just services that you may find in a residential treatment, including, exercises, music therapy, employment or education support as well. So talking about the medical, services that are provided, here is a national study conducted in the United States, looking at therapies offered at residential addiction treatment programs in the United States. 368 programs were studied. About half of them offered detox. About a third offered OAT only for detoxification. About a third offered OAT as maintenance therapy, while a huge proportion actually did not offer OAT, that's about 40%, while just 1/5 discouraged people from using OAT. So here is an example of residential treatment for special population, like the indigenous. And indigenous residential treatments may include non-indigenous treatments with incorporation of their traditional values and cultural practices. And examples of that are provided here: sweat lodge ceremonies, smudging, drumming, etc. And it's also important to note that indigenous residential treatment, the services they provide may also vary across different residential treatment. So here is a systematic review of studies, examining effectiveness of therapeutic communities from 2000 to 2012. So 11 studies, including both traditional and modified therapeutic communities, were reviewed. They were randomized or quasi-randomized control trials of therapeutic community intervention with follow-up of at least 6 months. So I'll be talking about the results of the therapeutic communities using these domains. So regarding the substance use, outcomes, there are mixed results. Some studies reported reduction in substance use. And in a study at baseline, all the participants reported substance use, and at follow-up, 46.5% had relapsed since leaving treatment. For this particular study, relapse was defined as use of an illegal drug on 3 occasions during any period of 2 months since treatment. So we can see here even, about the heterogeneity of the studies, despite the fact that it was reported that there was significant reduction in substance use compared with usual treatment. And for the social outcome, they found improvements in social engagement, employment, housing. Regarding criminal outcome, a study found the mean legal composite addiction severity index score significantly reduced from baseline to follow-up, indicating that there was reduction in criminal activity. So various studies actually have shown that therapeutic community is an effective approach in dealing with substance use disorder and other related psychopathologies. However, only few randomized control trials have been conducted, and there is insufficient evidence to determine which treatment model is superior when compared to other treatment modalities. So regarding modified therapeutic communities, from research, they're said to be cost-effective and therapeutically effective treatment for certain subgroups of people, especially those with severe substance use disorder and social and psychological problems. So here is a more recent updated, systematic review of effectiveness of residential treatment, including, therapeutic communities. And this systematic review includes studies from January 2013 to December 2018. This particular review included 23 studies. 8 studies were rated as strong quality, 5 as moderate, and 10 as weak. And these quality ratings were highly impacted, by, attrition at follow-up and also the methodology behind the studies. This, regarding the substance use outcome, there were also mixed, results, although generally overall they reported that it showed improvement in substance use after residential treatment. A strong cohort study conducted by Bergman et al. In 2014 investigated differences between 141 coexisting mental illness and 159 substance use disorder only young adults attending a residential treatment. Results showed improvements for both groups. Percentage of days abstinent at 3-month follow-up was 94% for those with mental illness and 92% for those with substance use disorder. While at 12-month follow-up, it was 78% for those with mental illness and 86% for those with substance use disorder. However, looking at some other studies, 2 high-quality randomized control trial studies found improvements in substance use outcomes in both the treatment and control group. The control group was actually the residential treatment, and they found out that the initial improvement in the residential treatment was not sustained over follow-up. Also, a therapeutic community program also reported a high abstinence rate of 80% at 12 months, but had a much lower follow-up rate of 47%. And it was also found that 82% of those followed up at 12 months were actually those that completed the treatment. So we can see heterogeneity in these studies, despite the report that it improves substance use outcome. With regards to mental health outcome, a strong Australian study with median length of stay, about 16 weeks, showed reductions in depression, anxiety, and stress to levels considered to be within normal ranges by discharge for those that completed the program. Then some studies also showed the maintenance of a decline in psychiatric symptoms following discharge for those with coexisting mental and substance use disorder, with high retention across the follow-ups. So for social outcome, there were not many studies, regarding this as well, although generally they reported improvement in social outcomes. A weak study showed that a minimum stay of 6 months in a therapeutic community was associated with improved quality of life compared to standard residential treatment and pharmacotherapy. However, these studies suffered from very high attrition at follow-up, particularly in the therapeutic community, with just 44% retention. And pharmacotherapy, the retention was just 29%. So this is also highlighting, the methodological problems in these studies as well. So regarding criminal outcome, there's limited studies regarding that and also conflicting results. So for example, a strong Australian study on heroin users found that commencing residential treatment was related to not engaging in criminal activity. However, another strong quality study, which had a very large sample size of about 53,000 alcohol-dependent individuals in treatment, showed significant reductions in criminal activity following inpatient detoxification and community-based pharmacotherapy, but not residential treatment. For mortality outcome, there were really very few studies about this, and it's found that those who engaged in residential services as their last type of treatment recorded had an increased risk of death in the first year following discharge. And there was, residential withdrawal detoxification presented the highest risk of death, followed by residential treatment. So in a systematic review of effectiveness of indigenous residential treatment, there were also conflicting results about whether participant outcomes for those in residential treatment were better than for those in non-residential treatments. There were challenges, and this includes the fact that there is not enough data to do a statistical comparison. Also, there's great variability among client populations, such as differences in age, indigenous group, the type of substance that they used, which actually makes the comparison between residential and non-residential outcomes quite challenging. So overall, looking at the effectiveness of residential treatment, prior reviews showed limited quality evidence for the effectiveness of residential treatment for substance use disorder. Review on studies 2013 to 2018 showed moderate quality evidence that residential treatments may be effective in reducing substance use and improving mental health, and that it may even have positive effect on social and offending outcomes. But however, there's still limited evidence to support effectiveness of residential treatment. There is insufficient evidence to determine which treatment model is superior. There's lack of consensus over best practices. So here are the some of the residents' perspectives about residential treatment. So here is someone talking about harm reduction approach or seeing that as a strong point. So I'll be reading out these quotes. The other centers, they only talk about abstinence. The brain can't keep up. I didn't even know that risk management existed. Yes, still on harm reduction approach being seen as a strong point. It didn't work totally this time, but it still brought me benefits. When I relapsed, I was able to spot the problem very quickly, and so to get help very quickly, without waiting for things to get the point of me finding myself in the gutter. So here is another person's view about contrast in treatment, that is abstinent approach at residential treatment compared to harm reduction approach outside residential treatment. I had trouble finding the same approach with regard to my care pathway. This created mad confusion, which had a negative effect and huge communication problems with my entourage. And talking about improved relationships following residential treatment, my daughters informed me that they were going to be sleeping at my place from now on. I used to be an alcoholic. Before, when they were on holidays, they came for the day, and then in the evening, they went back to their grandmothers. On improved relationships, I'm sorry I made my mother suffer so much. Today, we have a much more peaceful relationship. We have made contact. Here is someone that has been futuristic. Get my nursing diploma. And someone talking about relapse after residential treatment and insufficient anticipation of stress outside residential treatment. When I left, I relapsed straight away. The change was too dramatic. And then my same old housing problems, not being able to find a job. And someone talking about the gap between support in residential treatment and lack of real social network in the real world. We are in a tiny cocoon in Kairos. There are always people to talk to, and when you go out, you find yourself all alone. So I'll be shifting gears now, talking about effectiveness of inpatient treatment. So a systematic review about outcomes for adults who had attended inpatient substance use disorder treatment reported decrease in substance use. However, there are several studies that have shown that attendance at inpatient programs is associated with higher risk of overdose death or opioid-related death compared to those who did not attend. A UK study which looked at the association between inpatient admission and opioid-related death found that the risk of opioid-related death increased substantially after discharge, with odds ratio of 4.3 in days 1 to 2 after discharge and 2.09 in days 3 to 14. Another cohort study of 276 substance users who were admitted to 11 inpatient facilities in Norway and were followed after discharge within 8-year period showed elevated risk overdose death within the first 4 weeks of leaving inpatient treatment. Here again, you see the heterogeneity of the studies. So it's been set to improve, mental health, as well as social support, employment, educational activity, potential increase in that, as well as housing. There's limited research around, looking at changes in self-efficacy, for example, housing, education, quality of life, following inpatient treatment. So basically, engagement in continuing care, motivation, and therapeutic alliance are the most important predictors of lower levels of substance use and abstinence after inpatient or community treatment. So talking about, limitations of effectiveness of these studies, there are quite a lot of limitations. The quality of studies has been predominantly poor. There's heterogeneity across the studies, especially around, the methodological designs, very limited use of randomized control trials, different measures of outcomes used, no specific definition. Example, abstinence versus reduction in use. Abstinence in some articles may be defined as, maybe 2 months after leaving residential treatment, use after 2 months. Some may say after 6 months. So it kind of varies across studies. Also, there is, selection bias as well. Most of the studies used, are retrospective. The selected participants may likely be those who completed the treatment. And I saw that in quite a number of the studies. So what happened to those people that didn't complete? What's their own perspective? What could they have contributed to the study? And this could also mean, the selected participants to maybe those that are motivated to complete the treatment, or also people that have the means to be able to attend the program. And it was also noticed that there's high attrition, at follow-up, lots of attrition there. Yeah. So also, there's also attrition bias as well. So those followed up are likely to have better outcomes, maybe better experiences with, using the residential treatment, and they're contactable, right? Because quite a number of them may not be in a prison or may not be in the hospital, so they were easily accessible. There were lots of variability amongst the participants with regards to their characteristics. For example, you may have studies that's just, in males, another one just in females or mixed population. So, which was kind of obvious and makes it kind of hard, of course, to generalize the study. So generalizability will be challenging for such studies. Also, there were various timing of follow-ups, as you can see from what I presented. Some of these studies had very small sample size, which of course reduces the power of the studies. Multi-component treatment models and varying descriptions, not consistent. Also, some had like substance use assessment at the beginning of the program, but at the end, there was just absence of the post-treatment related data. So areas of future research, of course, includes having better collection of the outcome data and conducting data linkage of key health, welfare, and justice agency administrative data to enhance understanding of risk and recovery trajectories, as well as future researching, looking at change in self-efficacy, housing, education, and quality of life following inpatient treatment. So here are the key points of this presentation. So basically, there is no standard definition for bed-based treatment, as well as, regarding the types, there's no standard classification. Even regarding the services that occur within this residential treatment, it varies across various residential treatment centers. And ideally, it's designed for people with moderate to severe substance use disorder that have significant challenge issues, especially with control of the use of their substances. Therapeutic community is a type of long-term residential treatment and is summarized as community as method. Community as method is the purposive use of the community to teach individuals to use the community to change themselves. Therapeutic community, based on research, is a therapeutic and cost-effective treatment for certain subgroups of people with substance use disorder, especially those with serious psychosocial problems. But it's also very important to know that most of the studies have some methodological problems, so one has also to be careful with interpretation of most of the results. So residential treatment may be effective on substance use outcomes, but the studies are impacted by methodological problems, just like I mentioned earlier. There are limited studies that actually compare the effectiveness of therapeutic communities to other residential treatment, as well as the conflicting results about these outcomes across residential treatment, as well as even inpatient treatment. Lack of consensus over best practices, and engagement in continuing care, motivation, and therapeutic alliance are actually the most essential predictors of reduced substance use and abstinence following inpatient treatment. And lastly, future research, of course, is needed to be able to standardize this outcome collection and make better data linkages. Thank you. And here are the references.
Okay, thanks, Funmi. So we have time for questions. I'll open up to, I'll ask online first. Anyone online with a question?
Sorry. Okay.
Okay, there is, David Reading is collecting his thoughts. He's going to type a question. Any questions from the audience here?
Sorry, I can hear you very well, sir. Sorry.
You can press that, then people online can hear as well.
Okay.
Hi, my name is Rebecca. I'm a social work student doing my placement with the Ethics Service Department at the moment. I just had a question from the beginning of your program, your presentation today about treatment centres and treatment-based care. There was a comment about assessments by peers and staff. And I was just curious about just the feature of self-assessment, if that came through in any of the studies or ever featured as well. just about the ideas around self-reflection as part of that process as well.
Okay, well, I didn't really notice that there was specific attention to self-assessment, but it was basically more like using that community method approach and having, being assessed by the staff and their peers, kind of, they contributing to the management of care for this particular resident. So it was more that community kind of perspective, not basically like an inward self-assessment, if I asked your question right. Okay, thank you.
David has, oh, go ahead.
Question. I don't know if I saw this correctly, but in one of the slides for the modified treatment communities, I think the rate of using OAT it wasn't as much as I thought it would be. Like not everyone subscribed to OAT. So I was just curious about that.
Yeah, they didn't really, so for that particular study, they didn't really say the reason why they didn't kind of, recommend oats, but it was more of a general study about what they do in this, the type of, like medication. Was basically talking about the use of OAT in residential treatment, but not specifically talking about the reasons why. But generally, from what I studied, most of the residential treatments, quite a number of them are more of, psychosocial intervention focused, like group focused. Some may use like OAT, some may not use like medication for the treatment and just solely focus. So that's why I solely focus on psychosocial intervention. So that's why I mentioned at the beginning of my presentation that it actually varies what occurs in different residential treatment. No set standard, it varies. People do whatever based on their own policy.
If I can chime in on that, I think it's a really important study and slide to highlight though, because I think it very succinctly describes how variable the kind of treatment you get in these centers can be. And that's in the US, but I don't think we'd expect much different in Canada. And so if there's that much variability that 2/3 of these treatment centers in the US don't even offer the gold standard in care for opioid use disorder, I think that is a really that really illustrates how difficult it is to interpret the literature beyond that. If there's that little standardization in what's even being offered there, then when you're talking about outcomes post-treatment, and there's so much variability in what treatment even means, I don't know what to do with that information. If you say, substance use outcomes are better or worse, mortality outcomes are worse, but we don't even know whether they got the basic gold standard in care, I think it really highlights how hard it is for us to make sense of those outcome data.
Right.
So we have I'm just going to go online quickly and then we'll circle back because we have some questions coming in online. So we have one question here from Fernanda over in Victoria, just asking about whether the majority of the studies that you were covering here were done in Canada or the US or elsewhere.
Okay, yeah, so there's a variety of studies across different countries, Canada, US, and even also developing countries, quite a number of studies too from developing countries. So I'll say it's a mixed studies, not specific to Canada or US, but just a variety of studies.
And another question here from Victoria from Dr. Reading. You claim that a key point for therapeutic communities is that they are therapeutic and cost effective, balancing the significant risk of bias in the positive studies, as well as the risk of potentially increased mortality in some studies that you've highlighted. How can we really say this? What evidence is there that this is cost effective in a way that's generalizable to BC? And I'll just continue on for that because there's a part two to this question that he has highlighted as potentially a little bit more answerable. Are there differences in efficacy and safety in different regulatory environments, such as the studies you've highlighted in Canada versus the US versus Europe?
Okay, so maybe just answering the first, sorry. Yeah, so answering the first question. Sorry, cleaners keep on TCs. Okay, yeah, regarding whether, TCs are therapeutic and cost effective or not. So I mentioned that, quite a number of the studies, especially the study about the systematic review about therapeutic communities, which actually included all the studies that they used were actually randomized control trials. They said, based on the studies, that it's therapeutic and cost-effective. That was the general summary of the studies. But they also highlighted, just like you mentioned here, from your question, Dr. Reardon, there's significant bias. They had methodological problems to issue. So there's need to be, of course, careful, based on different outcomes, all the, limitations that I mentioned earlier. But this was just like a kind of general overview of what they found, but still has lots of limitations, I agree.
And then his second question was just whether we could interpret the evidence by a regulatory environment, or whether there are environments where where such programs are more carefully regulated.
Well, to be honest, I didn't really go into this, but this is something that is worth checking out. Then if I have the answer, if I'm able to contact you, Dr. Reardon, I think I'll be able to provide that. But I know that there is one being Therapeutic Community in Northern BC. I just saw that, when I was trying to read up this. So I really don't know so much about the program, and I don't know the regulatory stuff around it, but it's something I can just find out more information around it.
There's, in BC at least, there's very little regulatory environment.
Yes. So.
Okay. Oh, sorry. Is there another question from the audience here? Yeah, Grace.
Right.
I was wondering if there were any studies or things in general on any of the treatment facilities that we have here in Vancouver. Curious about any.
I wasn't, to be honest, I wasn't paying attention to Vancouver, and I didn't really like I said, I just looked at studies generally from different countries, so I wasn't really paying attention to Vancouver, to be honest. So I really wouldn't be able to answer that, but I see you around. I can always provide that answer when I see you if I find something.
I'm not aware of any publications from British Columbia ever that look at our treatment system. Part of that is the fact that our treatment system is not it's largely private, and it's largely pretty opaque as to what happens in many of these centers. There's not a lot of publicly available data on processes or outcomes from many of our treatment facilities. That was actually called for at least 2 times in the last 2, if not 3 corner death review panels. About more oversight and reporting from treatment programs in BC, so that we can actually ask those exact questions. So one more question here, again around related to the lack of standardization and practice guidelines, and how that does make it really challenging to compare programs to each other or to alternatives. The question here is, would it perhaps be more beneficial to look at points of difference in order to make recommendations for conformity and consistency of practice?
To make recommendations for conformity? Well, I think the only based on research that I saw is basically more of just doing more research around, standardization of outcomes, but providing exact recommendations for this conformity. I would say more around, maybe conducting research more about that standardization of outcomes, basically treatment outcomes, and collection of data.
Okay.
And linkage of data appropriately.
Okay, we're coming close to time. I'll ask one more question then before the end of the session. And I'm just curious, for me having, an interest in this area and having done a pretty deep dive into the literature, if you could make a change right now to our system, either in terms of the way that it functions or what we know about how to best design it, what would you like to see if you could change our system here tomorrow?
That's actually a tough question. Well, if I could change the system, I would say especially I would say more around the hot topic now, right? About, people being forced to treatment and all. I would say more about, doing some research around that more, basically. I would say than just doing, just going around just making such a very drastic change by saying people should be forced voluntarily for treatment, involuntarily for treatment. I would say one of the things that I would want to change is kind of really look at what is research saying, what is the evidence around that, before proceeding to make such a huge change. Because basically from research standpoint, there's very limited evidence that this actually works. There are some studies that have highlighted that it could have potential benefits. Some say it has, harms, but how effective is it? It's not really known, right? And also, in fact, there's a study, a Canadian study, but it was about forced treatment in Thailand. What they found was that after people left the treatment, they relapsed in less than a year to injecting, drugs, because prior to then, it just helped with short cessation of injection of drugs. And after they left the treatment, less than 1 year after that, they relapsed. And also there's also studies about the risk of overdose after leaving forced treatment that's quite high. So I would say taking a step back and looking at what evidence that supports that before making a decision, I would say. Thank you.
Okay. All right. Thank you, everyone. Thanks for attending, and thank you for me.
Great, thanks.
And let's see, I believe we have the second week of November is our next session. So we'll hopefully see you all then.
Thank you, everyone.
Thanks.